Hello, welcome to Module 4 lecture on the assessment of senior fitness. This is Dr. Ruby. During this series of lectures for Module 4, we will address pre-exercise screening, field-based physical and mobility assessment, and laboratory-based physiological assessment. Please be sure to download the lecture notes to go with the lectures. Why do we pre-screen? Well, it helps us to identify a risk level and determine the need for medical referral. It helps you identify the client's health and disability status. It helps you identify signs and symptoms associated with certain diseases or conditions that might be of concern. Combined with a fitness screen, the pre-exercise screen helps to ascertain the most effective exercise program for your client. It determines a client's readiness for physical activity, and it identifies the client's goals, interests, barriers, motivation, quality of life, family support, and psychological state. What exactly is a pre-exercise screen? Well, it is a process by which we obtain information from a client prior to any performance or physical testing or training. We need several tools to perform the pre-exercise screen. These include an informed written consent that the client signs, a physician's consent form, a completed readiness scale or a PAR-Q, a health history and a physical activity questionnaire, and any other tools that evaluate coronary artery disease risk factors, body composition, or blood pressure. There are some contraindications to performance testing. Any one or more of the following symptoms would warrant a referral to the client's physician rather than the performance test. Pain or discomfort in the chest, shortness of breath at rest or mild exertion, dizziness or fainting, swelling around the ankles, fast or irregular heartbeat, pain in the lower legs, something we call intermittent claudication, indicating that there may be a blocked blood vessel in the leg, heart murmur or undue fatigue. There are risk factors specific to coronary artery disease that we should watch for, and it is our primary reason for pre-exercise screening. There are several risk factors to consider, such as age, family history, smoking, hypertension, and that would be a systolic blood pressure of greater than 140 and a diastolic blood pressure of greater than 90. High cholesterol, that would be low high-density lipoprotein, the good cholesterol, diabetes, obesity, and sedentary lifestyle. Many of these initial risk factors can be seen in the ACSM's guidelines for exercise testing and prescription for 2014. If you look at the grid below, we show that there are categories of low risk, moderate risk, and high risk. Low risk are men under 45, women under 55 who are asymptomatic and have no more than one risk factor. Those at moderate risk of coronary artery disease are men over 45, women over 55, or individuals of any age with two or more risk factors. And those at high risk are those with one or more signs or symptoms of cardiovascular or pulmonary disease or any chronic vascular disease, pulmonary or metabolic disease. There are screening steps that we should follow when doing the pre-exercise screen. First is the informed consent. Step 2 is the physical activity readiness questionnaire or the PAR-Q. Step 3 is the physician consent. Step 4 is the health history and activity questionnaire. And step 5 is any feedback that you provide to the client and their confidentiality. There are other pre-exercise screening tests besides the ones we have mentioned so far. These are used to gain further and more in-depth information about the client. One of these is blood pressure, and this should be addressed in the health history, but it can also be directly measured. Here's a link where you can look at the classifications of the American Heart Association's blood pressure guide, and we'll give you some ideas of what to look for when evaluating blood pressure. The body mass index, or the BMI, is used to assess body composition, and this can be a very helpful tool. We want to look for a desirable range of 18.5 or 24.9 kilograms per square meter for men and women. We can also look at the waist to hip ratio and waist circumference, where we want to find a lower value for waist circumference as a safety aspect to their exercise program. There are also field-based physical and mobility assessments. So after a health pre-exercise screening, assessments of physical impairments and functional limitations can further aid in developing the most effective and individualized exercise program. These are often omitted or overlooked due to time restraints, budget, insufficient personnel, lack of appropriate tools, and lack of training of personnel. But they are very important things to look for. Physical impairments include any declines in specific body systems such as the musculoskeletal, cardiovascular, and neurological systems. And functional limitations include restrictions in physical behaviors such as rising from a chair, lifting, or climbing stairs. For this, we look at the functional fitness framework. This is a progressive relationship between the physiological performance, functional performance, and the activity goals of the client. You can see this framework at the links below and a published article by Rickley and Jones on the functional fitness framework at this link. This framework notes that if physical impairment exists, functional limitations may develop or exist, which can potentially lead to physical disabilities and dependence and a working interrelationship. There are several considerations for test selection and evaluation. First, the practicality. Is the test usable within the conditions at hand, the time of the test, the expertise of the personnel administering and scoring the test, the space, the level of fatigue, and the socially acceptable and meaningful aspect to the client? So highly specialized lab equipment may not be practical in a field test. We may need to do something more simple. We may also be looking at the psychometric properties to consider if the test is one that is appropriate. Things such as reliability, validity, discrimination power, and performance standards are all considered when choosing your test. Let's take a deeper look at the psychometric properties of the testing instrument. When you look closely, you'll see that your results are ultimately tied to the quality of your instrument, and this quality can be measured in many ways. First, reliability. We can look at both inter-rater reliability and intra-rater reliability. When we say inter-rater reliability, we are looking at the difference in measurement ability between two different experimenters. When we look at intra-rater reliability, we are looking at the ability of one experimenter to repeat the measure effectively. We can also look at validity, and this can be measured in three ways. We can look at it from a criterion-related way, a content validity, or a predictive validity. With criterion-related, we're looking at a correlation analysis to compare two different tests. With content of validity, we're looking at the ability of the test to measure the domain of interest. So does the test actually measure what we're looking for? And then lastly, the predictive validity. Can we apply what we measure to what we want to find? So for example, does a low performance on a Berg balance scale really predict a high risk of falls in older adults? We can also look at discrimination power. For example, floor effect is when the test is too difficult. A ceiling effect is when the test is too easy. Responsiveness is the ability to detect meaningful change over time, where continuous scores have more meaning than category. Lastly, we can look at performance standards, so norm reference standards versus criterion reference standards. Norm reference standards are test results that are evaluated in comparison to others of the same age and gender. Criterion reference standards are test results evaluated in relation to a particular reference point or a goal of interest. Let's look at some recommended assessment tools in field-based assessments. The first tool is the SFT, or the Senior Fitness Test. This test measures underlying physical parameters of functional mobility and the ability to perform functional tasks of daily living. There's a brief summary of the SFT test items in your textbook, and you can see the risk zone for each exercise. This test uses the United States Norm Reference Standards. It uses a continuous scale scoring which increases responsiveness of behavioral changes over time. Older adults can perform the test items very safely and within a good range of discrimination, practical and easy to use. The Fullerton Advanced Balance Scale is another common test. It measures multiple dimensions of balance in different sensory environments. It's developed for higher functioning adults. There are 10 items that are scored on an ordinal scale of up to 40 points. It is demonstrated that high test-retest reliability and inter rater reliability are very good aspects of the Fullerton Advanced Balance Scale, and it's used quite consistently between trained professionals and has a good construct validity. Other commonly used physical performance tests that we see in the literature are the short physical performance battery, the usual gait speed, the 6-minute walk test, and a continuous scale physical performance test. You can see all of these in ACSM's guidelines for exercise testing and prescription. There are many guidelines for group testing. First, we must look at administering the training for the experimenters. We need to select first the appropriate test that supports the psychometric properties addressed, such as reliability, validity, discrimination, and performance standards. And then we need to purchase and collect all necessary equipment and result recording sheets. We need to become familiar with the test and the testing procedures step by step. For example, will you need any assistance? What is the best way and how many to test in a group? Then we must practice the testing procedure on a small group prior to testing the target group. Lastly, you need to schedule your clients. On assessment day, you need to see that you have completed your 5 screening steps. The clients have read and signed the informed consent. They've done the PAR-Q. You have physician consent. You have a health history and activity questionnaire, and you've given feedback to the client. Arrive early to the testing session. Provide a general warm-up with flexibility exercise no longer than 8 to 10 minutes with minimal exertion. Test all clients using the same instructions and procedures. Divide and send them to the testing stations, and then check all record sheets for readability and completeness. Treat all data collected as confidential. Try not to use subject names, use subject IDs, and store all records in a secure place. When interpreting the results, look for a comparison and change of behavior over time. Try to go by performance norms for completing test scores to others of the same age and gender. Look for criterion standards for comparing test scores to some criterion or threshold that helps to identify those with higher risk for mobility issues, falls, or disability. Think about this. What are the benefits of these field and mobility-based assessments? How will they help us increase our success with our clients? This concludes part 1 of the lecture for Module 4.